All right, so let's continue the conversation about water conservation. We've already talked about this portion. So just to recap, the kidneys will filter the blood. That filtrate will start in the glomerulus, the glomerular capsule, and will start moving into the tubes as well as the collecting duct. And as it does that, you'll get more resorption. So if there's something that the body wants or needs, like sodium or chloride or potassium or whatever, or water, then those things will be removed from the tubules and back into the body. And when it does that, the urine will become more and more concentrated as it moves forward. So the collecting duct, well, most of it you'll notice is in the medulla, but it begins in the kidney cortex, and several different nephrons will start to feed urine or filtrate into those collecting ducts. Um, and as it moves through, again, it'll start to resorb uh, what it needs. So definitely water in the medulla. This collecting duct is much more permeable to water than it is sodium chloride. So you are less likely to have sodium chloride leave the collecting duct while you have more water leaving the collecting duct. And this will make the urine more and more salty as it gets more concentrated. So this is a summary of the process. Make sure that you're looking at this, have a general understanding of what's going on, be familiar with it. All right. The structure of the the structure of the nephron with the glomerulus, the PCT, the DCT, the collecting duct, etc., the loop of Henry, the descending portion, ascending portion. This is the thicker portion, and understand that you have different materials that are going to be more or less permeable in different areas. Now, let's talk about what your urine is made of and some of the properties of urine. So we already know that urinalysis is the analysis or examination of urine. What is in the urine? What does the urine look like? What's going on there? And that's going to tell you what's happening in your body by looking at the components inside the urine, the waste products inside the urine, or just the spillover. The first thing is you're going to look at the color. So when you are doing your analysis, you want to be the one to look at that patient's urine color. You can start now by looking at your own urine color. All right. So when you go to the bathroom, pay attention to what it looks like. Do understand that if you're urinating in the toilet, which of course we are going to do, that's already going to be more dilute than when you urinate in a cup because you're already putting it in water. But just keep these things in mind. So the color of urine is going to vary. It can be very clear for someone who's passing lots of water and with urine that is very dilute, or it can be a pretty dark color. So this says dark amber. So if there's variation in colors depending on how hydrated the person is and what else is going on in that person's body. So yellow can be due to the breakdown of hemoglobin. If it is cloudy, so that's another thing you want to make sure that you're paying attention to. Is it cloudy? Is it clear? Meaning no clouds. So clear doesn't necessarily have to do with the color because it can be yellow and clear or deep amber and clear, right? So cloudiness or blood can suggest that a person has a urinary tract infection. So if there's a lot of bacteria, that can make it cloudy, and that can also cause, of course, the bleeding. If a person has sustained trauma, if they have any kind of stones in the kidney or in the bladder, or it might just have other fluids that is contaminating the urine. So if in the collecting cup there was something else, etc., that can cause the cloudiness, or it can cause your the color to change in your urine. Pyuria. Pyuria is the term for pus in the urine. So if a person has an active infection in somewhere in the urinary tract, then they'll have pyuria. So the suffix urea means urea. I'm sorry, it means urine, and py refers to pus. Hematuria, remember, hemato is referring to blood. Urea, again, refers to urine. So hematuria is the medical term for blood in the urine, and there can be several different causes of that. The next property that you want to pay attention to is odor. Now, of course, that doesn't mean that we want you to take somebody's urine and stick it up to your nose. That's kind of gross, but using your senses when you are working with patients is going to be key to you being a great clinician. There are lots of things that you can detect by the way it smells. So if, as you're working with this, you notice that there's more of an ammonia smell, or there's more of a asparagus smell, or it's more of a sweet smell, then you can begin to use that information to help you decide how to further test your patient to figure out what's happening with your patient. The specific gravity. So the specific gravity talks about how many things are dissolved in that water, in that urine. The more that's dissolved in the urine, the more density this sample is going to have. And that is the specific gravity. So when they're talking about specific gravity, they're comparing it to distilled water. Distilled water has a specific gravity of 1. That's like the standard, because distilled water should not have anything in it except H2O. So comparing that to other substances, you can say that if this is 1.0, then anything more than that has a specific gravity of whatever those numbers are. Urine ranges from 1.001, really close to the density of distilled water, to 1.028. All right, so that is the range. So it never gets to 1.1, not even 1.5. That is the range, very tightly. It's a very tight range, but it's a very important range to know. So definitely know this information. Osmolarity. Osmolarity talks about the concentration of solutes in a solvent. Solutes in a solvent. And this ranges from 50 milliosmolar per liter to 1,200 milliosmolar per liter in a dehydrated person. So the idea is that the more concentrated the urine, the higher the osmolarity, because there is more solute in the solvent. Next, you have the pH. So urine pH could potentially range from 4.5 to 8.2. Usually you'll have this mildly acidic pH of 6. But there can be a great range to this depending on what disease processes is going on in the person's body, what medications you're taking, what you're eating, your state of health, etc. And then you have the chemical composition. So what is actually dissolved inside of the water? Urine is 95% water, roughly. Of course, that varies depending on how hydrated the person is. And you have 5% solutes, so 5% other substances. The normal substances that you will find in your urine are urea, sodium chloride, which is table salt, potassium chloride, creatinine, uric acid, etc. You can read this list on your own. Abnormal things to find in the urine include glucose. So remember earlier in a previous video, we talked about how your blood, once it is above 220, then you'll start to get some spillover into your urine. All right. So the body, you shouldn't have more than 220 in a healthy person. But if you do, then you'll find this abnormal finding of glucose in the urine. Free hemoglobin. Free hemoglobin should definitely not be in the urine. Albumin, which is one of the main or the main protein found in your bloodstream, that shouldn't be in the urine because, of course, those fenestrated membranes or the fenestrated cell layers should not be large enough for a protein molecule to actually leave. So if it does, then you know there's something going on with the kidneys that it's not able to keep things in that's supposed to stay in. Ketones are not normal in the urine. Now, your body does, well, historically, our bodies are designed to go through times of feast and famine. And when there are times of famine, then your body uses your resources or your reserves, which are your fat molecules, your adipose tissue. So that is not uncommon, but it doesn't happen all the time. So if a person consistently has ketones in their urine and they're not trying, then you know something's going wrong. And biopigments. So none of that is normally found in the urine. Now, the terms that describe the volume of urine you have are these. So normal volume for a person, we already mentioned before, is 1 to 2 liters per day. If a person has more than 2 liters, we call it polyuria. Poly means many or much. If a person has less than 500 mils per day, so they're not drinking much water, they are dehydrated, they are hot, and hot, etc., you'll have oliguria. And then anuria, 0 to 100 mils of liters per day, you basically are not urinating. So there's a low output from kidney disease, dehydration, circulatory shock, prostate enlargement. All of those can stop your body from excreting urine. Low urine output of less than 400 mils per day. The body can't maintain a safe low concentration of waste in the plasma. All right. So there's that. Now, in diabetes, we know, or maybe we don't know, so let me not assume that. One of the telltale signs of diabetes is polyuria. So again, polyuria is an excessive output of urine, so more than 2 liters per day. When a person is urinating a whole lot and they don't know why, as a healthcare practitioner, one of the first things that you want to rule out is diabetes. So have them urinate in a cup, do a urinalysis, and basically let them know if they're spilling urine. There are at least 4 types of diabetes. So diabetes type 1 is your autoimmune disease. This was historically called juvenile onset diabetes because it's mostly found in children up to it. Well, it used to only be found in children up to about age, to young adults, so about 21. You have type 2 diabetes, which is the diabetes lifestyle. So basically, long story short, a person ate themselves into a diabetic state. You have gestational diabetes. Gestation refers to pregnancy. So this is the diabetes that occurs during pregnancy in some women. And then you have diabetes insipidus, which actually has nothing to do with blood sugar. It is a form of polyuria that is more associated with endocrine system. So the 3 types of diabetes that have something to do with blood sugar, here you have high concentration of glucose in your renal tubules, Um, Glucose opposes the osmotic reabsorption of water, which makes it so that you have more water that passes in your urine. So your urine becomes more dilute because your body is not able to reabsorb as much water. In diabetes insipidus, you have ADH hyposecretion. So because it's not being secreted very much, if at all, then not enough water is going to be reabsorbed, and that's going to cause the urine to be more dilute. Diuretics are chemicals that increase the volume of your urine. Some of them do this by increasing your GFR. Things like caffeine can dilate your afferent arterioles, which will increase your GFR, which will cause you to pass more water in your urine. Some of these diuretics will reduce the tubular reabsorption, so it won't allow those tubules to reabsorb the water and bring it back into the body. This is one of the things that alcohol does. It inhibits ADH secretion so that you have less reabsorption of water from your tubules, tubular reabsorption. This is why when you drink, you might urinate more and more because of that. Some of the diuretics will work on your nephron loop. These are called loop diuretics. So you may have heard that term in pharmacology or when you were watching a television show. This inhibits that ion transport. So the transporter that will remove your sodium, potassium, and chloride, your loop diuretics will inhibit that. Diuretics are commonly used to treat hypertension and congestive heart failure so that you don't have as much of a fluid volume, and that can decrease the blood volume, which decreases your amount of blood pressure. It also helps to decrease the amount of work that the heart in congestive heart failure needs to do. So renal clearance. Renal clearance refers to the volume of blood plasma from which a particular waste is completely removed in 1 minute. So when we're thinking about, this is especially important when you're talking about medications. So how quickly is your body going to remove this substance from the body in 1 minute? All right. This represents the net effect of 3 processes. So you have your glomerular filtration, the tubular secretion, and the tubular reabsorption. All of these added together, or added and subtracted, of course, make up your renal clearance. So in order to determine the renal clearance, you need to collect some blood, collect some urine, measure the waste concentration in both of them, and then measure how much urine a person is, how often the person is urinating in a particular amount of time. So you have your waste concentration in the urine, that's represented by U, how quickly or how much urine is being excreted, that's V. P is going to be the concentration of waste in the plasma. And then C is the renal clearance. So you have these values, and the way that you calculate the renal clearance is by multiplying the U by the V and then dividing that by P. All right. Compare your renal clearance to your normal GFR of 125 mils per minute to see if the normal rate of clearance is occurring. If So no, not if. In the above example, it's 48%, which is normal clearance for urea. So this is how you determine renal clearance. Yes, you will need to know these factors, what these stand for, and you do need to know this equation to know how to calculate those things. So GFR. So again, GFR is one of those tests that are done on a regular basis to assess a patient's overall health, especially since it's non-invasive. You can get a GFR or you get a GFR value when you do a CMP, a complete metabolic panel. GFR, you cannot use the clearance rate of urea because of reabsorption and secretion of urea influence clearance. So because your urea is so influenced, the amount of urea that is excreted out of the body is affected by both reabsorption and secretion. And remember that secretion is what happens when your blood goes through the glomerulus, but there's still something in there that in the blood that the body wants or needs to excrete further down in the vessel. That material can be diffused into the collecting duct. So remember, please go back and look at the definition the definitions of reabsorption as well as secretion and where both occur. So when you're trying to look at the glomerular filtration rate, you need to use something that is not going to be secreted or reabsorbed. And that is inulin. So inulin is a polysaccharide that is produced by a plant, right? And so when they need to test the GFR, they can use inulin because, again, it's not reabsorbed, it's not secreted. So any of the inulin that is in the urine is in because of glomerular filtration. So they can inject the inulin into the bloodstream and then collect the urine to see how much is actually in the urine in a particular amount of time. So the inulin clearance, not insulin, please do not get the two mixed. In this case, inulin clearance equals glomerular filtration rate. Now, clinically, when they're doing GFR, they're not injecting inulin into people. Usually when you are doing a urinalysis, they're just measuring what's already in the body. So in this case, clinically, they're going to use creatinine. And remember that creatinine is a waste product that is created by using creatine. Yeah, creatine phosphate. So you don't have to have any injections, and the amount of error that can occur in that sample is small enough that it's acceptable and we don't have to worry about it. So let's talk about storage and elimination of urine. So urine is being produced constantly. As long as your blood is flowing through your body, then the blood is flowing through your kidneys. And so your kidneys are constantly and continuously producing urine by cleaning the blood. It does not drain continuously from the body. Urination is episodic. So it happens every so often when your body actually allows it. It's being made all the time, but it's not always draining. And this is made possible by storage apparatus and by the way your neurons control the release of urine from your bladder. Kidney stones. So kidney stones, the word calculus means stone or hard. Um, so renal calculi are kidney stones. These are uh, stones. So these are hard substances that are created from different things. There are different types of stones in the body. You have calcium phosphate stones, calcium oxalate stones, uric acid stones, or there's a magnesium salt stone called struvite. These will generally form in the renal pelvis. So again, look at the anatomy, go back and look at your kidney anatomy so that you know where the renal pelvis is. Normally, they are small enough to pass out of the body through the ureters, through the urethra, unnoticed, inside the flow of urine. But if they get large enough, that's when they can cause problems. They can block the renal pelvis, they can block the ureters. If they block either one, they can cause the pressure to build up in the kidneys because, as we said in a couple slide or so ago, the kidneys are constantly creating urine. And so because they're not able to drain when it wants to, then you have this pressure buildup because you have the water buildup. And that can destroy your nephrons. Basically, just too much fluid in that space, too much pressure can definitely destroy those delicate tissues. And if you have stones that are large enough, remember that just because they're stones, they're not always smooth. So those edges can cause a lot of pain because it can scratch the surface, scratch the edges of the tubules, and that can, I'm sorry, not tubules, the tubes. So the ureters and the urethra, if it makes it down that far. So when it scratches the edge, it's going to be extremely painful, and it might even cause damage to allow for, which causes there to be blood in the urine. So causes of kidney stones: hypercalcemia, meaning too much hypercalcium in your blood, hypercalcemia. Might be dehydration. You're not drinking enough water to flush out some of the chemicals that are making up the stones. pH imbalances. So remember in your chemistry classes, when you did experiments, you would get precipitate when you put certain things together. Changing the pH of a solution can cause that precipitation, and that precipitation can continue and cause kidney stones. If a person has frequent urinary tract infections, or if a person has an enlarged prostate that will not allow for your bladder to empty as frequently as it needs to or as completely as it needs to. And in that case, the fluid will back up and can eventually cause kidney stones in that person. So treatment for kidney stones will include things like medications that might dissolve stones, surgery if the kidney stones are large enough, lithotripsy. So litho, make sure that you look that up to look at it for yourself. But this basically refers to a stone. Lithotripsy is when you take sound waves, concentrated sound waves, point it directly toward the stone, turn on the sound waves, and those sound waves can basically take the stone and blow it up, cause it to pulverize, so that there's a bunch of little pieces instead of big stones, and hopefully the person can pass those little pieces much easier because they're smaller. So different types of urinary tract infections. Urinary tract infections, there are several different types. You have cystitis. So remember that cyst refers to a sac. All right. So cystitis is inflammation of the sac. And in this case, The sac is talking about the urinary bladder. Very common amongst females. So women get cystitis or UTIs more frequently than males because of the shorter urethra. As I mentioned in class, ladies, you want to make sure that you are urinating after sex so that you decrease the chances of getting a urinary tract infection. Fellas, you want to make sure that you let the ladies that you are with know to drink water, or just have some water near you, so that when you're finished, have her drink some water, and so that she can urinate and not have a UTI, because that doesn't feel good. When you have cystitis, cystitis, it can that infection can spread if it goes up the urethra. It can cause up the ureter. It can cause pyelitis. Pyelitis is inflammation of the renal pelvis caused by infection. And then pyelonephritis. So pyle refers to the renal pelvis. Pyelonephritis, nephro refers to the kidney. So pyelonephritis is inflammation of the cortex and the nephrons caused by infection. This can also result from blood-borne bacteria. So if instead of the infection traveling up the ureter causing the infection, if you have an infection in your blood, and of course your blood is being filtered by your kidneys, that bacteria can settle in the kidneys and cause infection there, and that can lead to this pyelonephritis. All right, so let's talk about voiding urine. Between acts of urination, so between the times that you're going to the bathroom, that is when your bladder fills. You have a muscle that that is in your bladder, that is in the walls of your bladder, that is called the detrusor muscle. That detrusor muscle will relax, and that will allows for the bladder to fill. So the detrusor muscle relaxes, the bladder can fill. Once the bladder is full, the detrusor muscle will contract, and that will help to push the urine out of the bladder. So that is the function of this detrusor muscle. Remember that sphincters are those round muscles that, excuse me, act like doors to allow things, when they open, it allows things to exit whatever organ it is, it allows things to exit one organ and go into another organ. In this case, we're talking about the urethral sphincters. When your bladder is filling, your urethral sphincters are tightly closed so that the bladder can fill. Sympathetic activity in the upper lumbar spinal cord will stimulate your nervous system fibers to the detrusor muscle to cause it to relax, and your internal urethral sphincter will tighten. Micturition. Micturition is the word for urinating, the act of urination. The micturition reflex is this. You have an involuntary spinal reflex that will partially control your urination. So involuntary meaning that you're not controlling it, right? So what happens is your stretch receptors will detect that the bladder is being filled. That will send a message to the spinal cord. Then that message will go back to the bladder from the spinal cord via those parasympathetic fibers. These signals will then excite the detrusor muscle, and So remember the detrusor muscle, when it gets excited, it will contract and that will push the fluid out of the bladder. It will also relax that sphincter so that when the detrusor muscle contracts, the fluid can actually leave through the sphincter and out of the body. So you have voluntary control. For voluntary control, you have your micturition center in the pons. Remember that the pons is part of the brain stem. The pons will receive signals from those stretch receptors. Once your pons receives that signal, depending on whether or not you're able to go to the bathroom at that moment, this is basically what it means when it says if it's timely to urinate, um, you will get signals going back and forth from the pons that will excite, relax, etc., so that you have urination. If it's not, then the pons won't excite, so that you won't have the sphincters opening, you won't have the detrusor contracting, etc. So make sure that you're reading this. Make sure that you're reading this. Understand steps 1 through 4 and 5 through 8 so that you can know both the involuntary steps as well as the voluntary steps. And this is a visual of that same process. So make sure you're going through this visual so that you can get a better idea of what's happening in the involuntary steps and the voluntary steps in your neural control of micturition. All right. So renal insufficiency and hemodialysis. Hemodialysis, or more commonly called just dialysis, is the machine that is used when a person's kidneys are failing, when they're insufficient, when they're not doing their job. Then the person will need to go on an they will need to use an artificial filtration machine to help clean the blood and then put it back into the body. So that is basically what a dialysis machine is. And if a person does not go on dialysis, they will pass away pretty quickly because all of your cells are constantly creating waste products from whatever products they are making. And that will toxify your body very quickly, usually within like a day or two, if your kidneys are not working at all. So that is why so many people need to be on dialysis, because their kidneys are not functioning the way they should. Renal insufficiency is a state in which the kidneys cannot maintain homeostasis because the nephrons have been destroyed to whatever extent. It could have been, like major destruction or not as major, but anyway it goes, there's some level of homeostasis that is not being maintained because the kidneys cannot keep up with clearing out the waste as the waste is being produced. There can be many causes of nephron destruction. The two most common causes are uncontrolled hypertension and uncontrolled diabetes. So both of those things will destroy your nephrons, which will decrease the function of the kidneys. You also have chronic kidney infections, trauma. So if someone gets into a motor vehicle accident and they're hit from the back, or prolonged ischemia or hypoxia, you're not getting very much oxygen in your body or to the kidneys for whatever reason. If a person has heavy metal poisoning or solvent poisoning, remember the kidneys are filtering all of this out. So having heavy metals or having these solvents, these chemicals be in the kidneys can destroy the tissues. If you have a blockage of the tubules, from transfusion reaction. So a person has a blood transfusion that can cause a blockage in the renal tubules, which can cause destruction. Atherosclerosis. So sclerosis means is a hardening. Athero refers to the vessels. So you have this hardening of the vessels that can lead to the destruction of the kidneys, or the inflammation of your glomeruli, right? So glomerulonephritis. All of those can cause destruction of your kidneys. Your nephrons can regenerate. Your kidneys can restore after short-term injuries. So if, say, you're exercising really, really hard, or you have some kind of trauma, but it's not major trauma, it's not long-term trauma, your kidneys can potentially regenerate and restore from that. The other nephrons that are not damaged might compensate for the lost kidney, or the lost kidney function by hypertrophy. Now, we have two kidneys, but do know the reason why we people can donate a kidney is because you don't absolutely need both kidneys in order to live and survive. If you have just 1/3 of one of your kidneys, you can survive, right? When 75% of the nephrons are lost, then your output of 30 mils per hour is insufficient to maintain homeostasis. So this is part of that renal insufficiency. This will cause azotemia, acidosis, and uremia will develop. You can also develop anemia. So again, hemodialysis is how a person's blood is then filtered to remove the waste from the blood. And that's it for the urinalysis, urinary system PowerPoint.